free. Let's take it away from the computer. What's going on, guys? No, just checking in with the lovely, the talented, and the very educated Dr. Erica Zelfand. Doc, say hello to the good people.
Hello, good people.
Perfect. Today is another episode of What's Going On in My Blood when it comes to testosterone replacement therapy. If you would like to know why I'm on TRT, please feel free to read the description below. But the only thing you really need to know is that I've been on TRT for a few years. This lovely and wonderful person has been managing my care for a couple. And we have new blood work. And this is going to be a more unique video compared to the last few we did because some changes are going to be happening with my regimen, where I am taking testosterone cypionate. I don't take an aromatase inhibitor. I'm not on anything supplemental beyond that for my hormones other than levothyroxine, and I take 160 milligrams every week. So keep that in mind, and we will dive in. We'll see what we learn, and I'm glad you're here.
And you're doing 160 milligrams, but you're breaking that up in 2 doses, right?
Correct. Yeah. So 0.4 cc's twice a week, usually on a Wednesday and then on a Sunday intramuscularly. And I've been doing it myself lately. Did I tell you that?
Really?
Mm-hmm.
Wow.
I every time I do it, I can't walk for like 4 days, so I'm not doing it probably great, but
okay.
Trying to be more independent.
You might not be getting in.
I don't go
far
for
enough.
I go for quad.
Oh, yeah.
Well, because I don't have the mobility.
Yeah.
Anyway.
Okay.
So what do we got?
So let's start over here, because we sent your blood to 2 different places. This is our blood count. So I always want to do a blood count for guys who are on TRT because testosterone stimulates the bone marrow to make more red blood cells. That can cause a condition called polycythemia, where you have too many red blood cells. That can, over time, increase someone's risk for having a blood clot. Not good. So I always want to do a CBC for my fellows like you who are on TRT. And I look at RBC, the red blood cell count, and that is lovely. That looks great. These other things tell me about the red blood cells. Do they have enough hemoglobin in them? Are they the right size? So on and so forth. And they look pretty good there. You are low in a type of white blood cell called the lymphocyte. I suspect maybe you were fighting off a bacterial infection or maybe something when you had this blood drawn. I'm not going to worry about it too much. If it's something that persists on future lab work, we can investigate it.
Does this mean I have cancer? Is that what you're telling me?
No, I don't think so. I think it means that you had your blood drawn in the middle of cold and flu season when we're always fighting things off. So not too worried there.
Well.
Then we do a metabolic panel. This tells me about kidney function, liver function. As per usual with you, your creatinine is pretty high.
Is that because I take creatine, or is it something totally different?
It could be because you take creatine. It could also be because you lift weights, so you're having some muscle, breakdown when that happens. And that's something we've seen before with you as well.
It's a consistent thing. Right.
And then we looked at your B12 levels. Those are pretty good. I like to see B12 over 800. Folate, I like to see over 19, and you're at 23.6.
Sweet. Why do you like to see them there?
Just functional medicine-wise, people feel the best in that range. And I think people are getting optimal ability to properly use those nutrients for the various processes that they're needed for.
Okay. Like
energy production, like mood balancing, like nerve health, stuff like that. And then PSA, this is a prostate screen. That looks fine too. This is another test that I like to do every once in a while in guys on TRT just to make sure that the prostate isn't angry.
And why is it important that you make sure the prostate isn't angry for guys on TRT in particular?
So there's some thought that if a man has prostate cancer already, and then you give them testosterone replacement therapy, that the therapy will actually exacerbate the cancer. And
if you have it.
If
so
you
increase growth.
Yep.
But if you don't have it, it's considered safe.
Yes, it is still being contended. So some people still say that this might increase the risk of prostate issues. Other people think that's bunk.
And that's just why you keep an eye on it.
But I just keep an eye on it just to make sure. And so if a guy, let's say he doesn't have prostate cancer, but his PSAs are going up and up and up on the therapy,
then
that's
it would
something
be concerning.
that, it catches my attention. So there's that. Now let's dive into this pretty one with the colors. These are so much fun. So we did a repeat cholesterol panel on you. We still have quite a few values in the borderline range. I'm going to scroll forward for a moment here. I almost prefer this chart better for looking at cholesterol because it tells us about the ratios. I'm realizing as I'm pointing, I'm blocking things.
Okay.
If I use a pen, maybe. Ratios, that looks better.
Oh, that doesn't.
Tells me about the ratios, so how much good to how much bad are you making? And as we can see, our ratios are still pretty borderline too. So these aren't terrible, and if we actually look back, I am gonna go back to all the things I'm skipping, don't worry. This is a comparison page, so this tells us about March 2015, July 2015, and now. So it nicely lists out what your lab results were, so we can look at them over time.
Right.
And actually, some of your values have improved. Your triglycerides have come down beautifully. This has been diet, so
yeah,
good work there.
It's probably diet related.
So yeah, nothing too alarming there, but
still, like,
you know, borderline. So keep up the vegetables and the fiber and the not just weightlifting, but the cardiovascular exercise. And then as far as increasing your HDL, that's your good cholesterol. So the things we discussed, fish oil can also be helpful for that. And I see vitamin D being really helpful for that. And as we'll see in a moment, your vitamin D levels are pretty low.
For real?
So, are you taking vitamin D?
No, I guess I'm not.
Okay.
I thought I was, but no, I don't think I am.
I think at some point that was on the list, but I don't feel like I've heard it come out of your mouth in a while, the vitamin D in your regimen.
No, I guess not.
We'll chat about that today.
We live in the Northwest, so we don't get a whole lot of sun, other than the light you emit.
Oh, thank you.
Makes sense that I'd be low on vitamin D, I guess.
Yeah.
Also linked to mood disorders, so way to not do something obvious.
It's alright, that's why we have these check-ins.
I guess so.
Yep. Scrolling ahead to your diabetes tests, these are great. So your hemoglobin A1C gives me an average of 3 months. How have your fasting blood sugars been? And they're good.
Good.
And insulin levels also look great.
Cool.
So nice work there.
Thanks, dude.
Yeah. You did all the heavy lifting.
I did.
That was a joke.
I know.
Yeah. So these are somewhat redundant because they were done up by the other lab as well. But I will scroll ahead to these things here, the TSH, the free T4, and the free T3.
So now we're getting into thyroid.
This is thyroid.
We're getting into thyroid. I sort of fucked this up, though. I screwed this up. Because I took the medication like 10 hours before.
Right. It's okay. It was enough to give me a sense. So your TSH, that's the signal from your brain to your thyroid. And that signal, I like to see it for people who are on thyroid replacement hormone, somewhere between 0.5 to 2.5. And we are at 3.64. So we're a little higher than I typically like to see it. Then when we look at your free T4 levels, this is what's actually made by your thyroid. That's actually nice in range. And then your free T3, that's nice and in range too.
That's good.
So it does seem like your brain isn't entirely happy with the amount of hormone that's floating around because it's making more TSH. Does that make sense?
Dollars.
Okay. So moving forward, we could actually justify doing a small increase in your thyroid medication dosage.
Okay.
And I think we did that in the past and you got a little skittish about it.
I don't know that the reason I got skittish had anything to do with the thyroid. You didn't think so. I didn't know. I just get very hypersensitive when I start taking anything different.
Right.
And I think my mind plays tricks on me.
Right. Says the guy who's doing 160 milligrams of testosterone sulfonate.
That's 20% less than what was before.
Yep.
Doctor.
Yeah.
Madam.
Okay. Dr. Madam.
And I had lowered it on your recommendation.
You have.
Dr.
You
Madam.
Have. Yes, that's true. So, one idea I have here is that right now you're doing 50.
Yeah, you want to go back to 75?
Well, I was thinking we could split the difference and I could give you the 25 milligram pills that you cut in half.
Oh.
So it would be 12.5 plus your 50, so you get 62.5. Oh. Really small bump.
Gotcha. But you're sort of like playing to my sensitive nature?
Yeah.
Nice.
Well, and I don't want to blow you out of the water either, because Thyroid over medication looks like anxiety
Anxiety.
and difficulty sleeping and palpitations and
All the stuff I love.
that we don't really need to crank up for you anyways.
Okay.
But thyroid under medication can also look like sleep trouble, and it can look like depression, and it can look like sadness, right? So I want to get you to that sweet spot.
You don't think I'm quite there? You think I'm close?
I think you're close. I don't think you're quite there.
All right, well, this sounds like a reasonable, easy-going change, so.
Okay. All right. So have your blessing then. I'm going to prescribe that. Okay.
Yeah.
Then we talked about the creatinine, then the vitamin D here. So,
It's almost under.
yeah, so 36. Their reference range is 30 to 100. And, you need it to be at least 30 for your bones to not break. So you need it to be at least 30 for good bone density. Functionally speaking, you want vitamin D to be at least 50, however, for proper immune function. And also vitamin D works at hormone receptor sites. So depending on...
Because it's a hormone.
It is a hormone.
Right.
Yeah, which
common
people don't
misconception.
realize.
Yeah, common misconception.
It's a vitamin, it's also a hormone.
Tricky.
So considering that we're dealing with hormonal issues with you, and that we live in Portland, where we get very little sunshine, and that we are working with depression, I think that we should increase, or it sounds like start taking again the vitamin D.
What would you have me take?
You've been doing nothing
I guess, yeah.
for how many months?
Long time.
Maybe 4,000
For real?
a day.
Cool.
So then hopping over here at the male sex hormones. So this is the part everyone wants to see, right?
We're on the
Okay, here we
hormones.
go. We're on the hormones.
We have to warm you guys up before we get to the good stuff. But yes, we are now officially diving in to probably the main reason you are all here. So thank you for your patience. But we want to give you like a full picture of things. Yeah, or like
You gotta know the context.
Context, and everything should be full circle. Exciting.
You're more than your testosterone level.
That could be a book. Okay, we're trademarking that right now. This is a verbal trademark.
TM.
You're more than your testosterone level.
Are more than your
That could be like a book to all those guys who grew up watching Arnold Schwarzenegger and like Jean-Claude Van Damme, who like think all life is being like buff and muscular. You can like tell them, hey, like, that was nice.
Yeah.
Let's go.
Oh, I'm glad you like that. So looking at your total testosterone levels, normal range is 249 to 836.
Yeah, but no one would feel good at 249. Who's gonna feel good at 249?
Probably someone in
Their 60s or 70s?
yeah, another decade of their life.
Anyway, sorry, I digress.
But regardless, you can't argue with the fact that this is through the roof.
Yeah.
Yeah, we're at 1,388 with
So-
our cutoff being 836.
Right. So my total testosterone is much too high, and this is the first time that I didn't do my blood draw on at least 72 hours, or the fourth day, which would be, I can do math, 96 hours.
Okay.
But still, 48 hours after I took just half my weekly regimen, that obviously suggests that I'm probably over 1,000 permanently, right? I'd be shocked if in a day and a half I drop into the hundreds. Point is, it's too high. And a lot of people have speculated that on this channel, and I've never been opposed to doing whatever needs to be done to make me healthy, especially mentally speaking. So I kind of see this as a good thing. Like, this sort of excites me. When I first started, I was put on 200 milligrams a week of testosterone stipulated. That was some time ago. And even though we've only worked down to 160, I'm ready. Like, I'm ready to do whatever I'm supposed to do. So. And
it could very well be, people often think that more is better, but being over-medicated actually could be part of why you're having some of the
lingering problems. Yeah, absolutely. I fully am on board.
Great.
I get it.
Good. And, just further evidence that this is warranted is when we look at the free this is the bioactive form.
Explain that. Would you please explain the difference between total and free?
Yeah. So, have you ever used, like, those hand warmers when you go skiing?
Yeah.
How, like, you've got the hand warmer, but in order to use it, you have to, like, crack a little thing in it, and then it heats up.
Yeah.
Right. So, like, the free testosterone is the hand warmer after, like, you activated it. So it's the form that really does a lot of the work.
So the total, like, the free is what's left to do
So your body out of the total, it then activates it to the free form, and that's the part that does, the things that we say testosterone is good for.
Got it.
So,
so I'm like double the highest part of the range. So
Yeah.
I have way too much testosterone in my blood. And I mean, does that mean my brain is coming back online? Does that mean with diet and lifestyle choices, certain things have naturally fallen more into place? Can we speculate? Is this just because I'm over medicated? Because why in the past haven't we been so obscenely high? Even like when I was on 200.
Right. Well,
that's the part that
you
confuses
have,
me.
For a while I have been telling you that you're over medicated,
Right.
and we've been going with the slow and steady route.
Right.
Part of it was you were also hypothyroid, and now we've got you on the thyroid replacement.
So you think that could have an
hormone.
implication
It's
on
all
this?
related.
Sure.
I mean, it's all endocrine system. It could be the other things you've said as well. Your body is getting healthier also.
Cool.
Now, I'm not quite sure if it means your testes are coming back online or not, because
FSH is
FSH
bottomed
and
out.
LH, these are totally bottomed out.
And so what is that, real quick, for anyone who doesn't understand this stuff very well? FSH and LH, just what's the context of that last comment?
Sure. And I was actually thinking, this is maybe not the best time to spring this on you, that we could maybe do another brief video just explaining, the hierarchy of the brain, the testes, what makes what, and then the difference between primary and secondary hypogonadism.
Well, I'll have to talk to the guy that runs the channel.
Okay, because I think you were diagnosed with the wrong kind, which is part of how we got in this situation. But to answer your question, the brain puts out FSH and LH, which then travel to the testes. FSH helps the testes, be the right size and get larger, and that actually helps produce sperm. LH goes to the Leydig cells, and that nudges the testes to make testosterone.
Got it.
So when you're on TRT and you've got all this testosterone floating around in your blood, your brain sees that testosterone and
says,
it's like,
"Don't
I'm just going to shut off the
send a
signal.
Got it.
Right, that would be redundant, that would be dangerous to have that much. So that's called suppression, when you get suppression happening.
Okay.
Progesterone levels are good. Estradiol is 30. It's a little higher. When it starts getting above 30, I'm like, maybe aromatase inhibitor. But you don't need an aromatase inhibitor.
We need to
just
lower the
your
testosterone,
dose.
right?
Because when you give your body testosterone, invariably some of that's going to turn into estrogen.
Absolutely.
So we're just going to give your body less testosterone.
Perfect.
Sex hormone binding globulin, this is actually a little low on you, and that's something that I'm hoping we can nudge over time. But
why is it so low? You don't even know, do you?
No, well, I think part of it is just being over medicated. Your body
way
can't.
low.
Yeah.
What are the side effects of having that so low? Do you know off the top of your head?
Well, sex hormone binding globulin, it binds to whatever sex hormones are ready to be eliminated from the body.
Oh.
So it actually helps control levels and prevent them from getting too high.
Interesting.
Yep.
Okay.
So then we've got our DHEAS. This is actually made in the adrenal glands, and your body does make a little bit of testosterone out of this as well.
So maybe that's something.
Yeah. So, here's the other thing. Your adrenals are probably coming back online, because when you first came to see me, you were totally adrenally fatigued.
Sure.
Right? And that's improved since we've been working together.
Okay. So what are we gonna do with this information?
Okay. Don't freak out.
No, don't freak out. Shoot, I have to pee again. Isn't that crazy?
It's not crazy.
I'm gonna literally
You want to pause it? You want to pee?
I'm gonna walk away and pee.
We have a few minutes.
I'm gonna be right back.
Okay.
I'm not gonna turn it off either.
You're gonna leave this thing pointed at me?
Well, so funny. You're like off camera.
I felt like someone was watching me.
No, I told you I would. I told you I was gonna edit it and turn it off. You're funny. All right, sorry about that, fellas. I've got the bladder of like a 7-year-old.
So where were we? I said, don't freak out.
Don't freak out. So we know my testosterone's too high. We know my free's too high. We now again must act, and I'm ready to do whatever I need to do.
Good. Okay. So you're on 0.4 twice a week.
Mm-hmm.
Let's do 0.5 once a week.
Whoa, dude! Why do you have to make it so extreme?
Because this is extreme.
Oh, what about the? Well, I thought we were gonna talk about
With the HCG. So here's what I'm thinking: that we can get you to, first of all, this is like, we just need to get that number lower.
You want to cut it almost in half?
Almost in half.
Dude, that spooks me, Doc.
Look,
that legitimately spooks me.
Don't run away. Come back. Look at this. Look at this. That divided by 2 is like beautiful, high normal. This divided by 2.
Oof,
My normal
spooks me. Really does. So you want to go from 0.8 to 0.5?
Mm-hmm.
I guess that's only 0.3 different. Can't we do 0.3? You don't want to do twice a week anymore.
Mm-mm.
You think that's part of the problem? Because see, the reason
Because eventually I want to have you do your testosterone once a week and then your HCG a few days before then.
So why aren't we starting HCG now? Is because you need to know where I would be.
I just want to get you lower first.
You just want to get me lower
So
first?
that I'm not totally making things up on.
Because do we know how much HCG is going to affect the levels? Is that part of the confusion? Is that we have to feel that out itself, so we need a lower baseline to go from there?
Well, I just need your baseline to be not crazy.
Right.
And so that way, once we start your HCG, then I'm having 2 therapies that I'm trying to balance.
Right.
Whereas if we just get your testosterone not crazy, and then I add on the HCG, it's gonna be less of a moving target. Even if you weren't starting HCG, this would still be my recommendation.
Yeah.
You're just too high now.
I know I'm too high. This has been
we've had this talk.
I know. This has just been a security blanket. Testosterone was the first thing that made me think I had a chance not to be severely depressed and anxious and I was going to die, blah, blah, blah. And then I realized it was just a piece of the puzzle. I soon accepted it wasn't going to be like some be-all, end-all treatment. I get it. And very slowly, we've been working down. I think this is just the biggest jump we've ever done. So just the idea of taking more away of something that I've always associated as part of the reason I didn't die, it just spooks me. And I mean this sincerely from the bottom of my heart. It's not about muscle. Guys bring this up like, you don't want to lose your gains. I want to be mentally stable and then let the chips fall where they may with my muscle mass. I don't care about that. Anytime anything big changes in any direction, I just get nervous. I just get I felt like my stomach turned when you said 0.5 because it's that's half of where I started. It just makes me nervous, but I'm assuming it's going to be just fine. I mean,
but you are not the person you were when you started. Yeah.
Agreed.
You are really different than when you started.
Yeah.
Your overall health picture is very different than when you started. And here's the other thing, Noah. If this is a totally failed experiment, we raise your dose.
The HCG thing I was really curious about.
Yeah.
I mean, I don't care what people think in the sense of no one dictates my treatment but you. But I did think but you know what I mean. But I did think we were going to be talking about how we would be starting HCG. When did you realize that wasn't going to happen right now?
When I saw these results and I realized how high this was.
Got it. So it's
I thought this was going to be 900 and I was okay.
We can work from there.
But when I saw these, I went, that's really darn high.
Yeah, that's really high.
So what I propose that we do, Noah, is that we lower your dose of your TRT, we raise your thyroid just a little bit, we get you on the vitamin D, and then we repeat your labs.
3 months or whatever?
2 months.
2 months.
We see where that is, and I want you to know that my ultimate goal at this time, of course this might change, but for a while now it's been to see you transition onto HCG. Because I don't think that you have a problem with your testicles. I think that it's a brain thing with you.
Gotcha. Well, but doesn't that go back to why was I low to begin with? Is that what you mean?
I think you were low to begin with because of a brain issue.
Because I was in a major depressive episode?
Well, who knows? Could be number of head injuries. Could have done it. Could have been, I hate to say it, could have been that shot. Well, I don't know. I don't know that that's been documented. But that was clearly a major assaulting event for you.
Right.
Or it could be, you do have a history of concussions, right? And head injuries,
and
ski accidents.
A couple concussions.
That can do it too. So, the issue when I look back at your labs before you ever went on TRT, your FSH and LH were low. So that signal wasn't ever reaching.
Before I even started TRT?
Yep.
Nuh-uh. I
So.
totally forgot that, if that really is the case.
Do you want me to pull it up?
Can you?
Yeah.
What? So right now we are looking at tracking down the original blood work in the couple minutes that we have left to see what my FSH and LH, perhaps what my T was as well, before I started treatment, which is really interesting. I didn't know you even had this.
Yeah.
Oh man, my stomach is just.
Maybe I'm wrong. Maybe I'm wrong, and it's good that we're double checking this.
Collection date. Yeah, that would be just before I started. Oh fuck! It's
LH. It was low normal.
1.2.
Okay. Low normal, 1.2.
What's the range again? Sorry.
Yeah, so here their range is 0.5 to 76.3.
To 76. So I was at the very bottom of this range.
Yeah. So what I would think is that if it was a problem with your testes, your brain would have screamed at your testes like, what are you doing? Make more testosterone, and that this number should have gone up. So the question is, why isn't that number going up? I
don't know.
Right? And that's the difference between primary and secondary hypogonadism. Primary hypogonadism is an issue with the gonads, with the testes. Secondary, it's an issue with the signaling from the brain.
How does that change treatment protocol?
So guys with primary hypogonadism, their testes aren't going to make testosterone, you give them testosterone.
Period, because that's just the way it is.
Yep.
Got it.
Secondary, that's an issue with the brain signaling. The testes work just fine.
Is that where
that's where the HCG comes
sort
in.
of thing comes
so you
in.
stimulate the testes so that they can still do the work in making the testosterone.
Got
You're
it.
just replacing the signal that the brain's not making. And if you're working with a functional medicine doctor like me, you try to do therapies to get the brain back online.
Got it. Sort of a similar concept as the levothyroxine. Hey, we're trying to stimulate T4 to convert to T3.
Right, which is why I don't have you on T4 and T3. I've just got you on T4 and your body's doing a gorgeous job of turning it into T3 as it's needed. So that's your LH. Let's see if they did an FSH.
Well, there's my original testosterone.
There's your original.
215 and 50. And that was one. I had another one drawn somewhere that was lower, but that was one of them.
I mean, you were 20 in your early 20s.
Do you see how their range is different than your range? And I've seen different ranges than even that one.
Yeah.
I mean, maybe that's a whole nother video, but the range seems to vary.
It does vary.
Which is interesting.
But, I mean, any way you slice it, today's less.
It's over, but I never wanted to go back to being low testosterone. Like, I'd be damned if I somehow ended up back in the hole of low testosterone.
Yeah.
But I don't think that's where we're headed. I think that's where I get nervous. Like, am I going to end up where I was when I got
I'm
this
not going to leave you in a hole.
blood draw or something?
Would I leave you in a hole? Answer me. Would I leave you in a hole?
No, you wouldn't leave me in a hole. I just get nervous.
Yeah.
This triggers old feelings, old fears, old stuff comes up when we talk about this.
Look at your FSH here. So their reference range 1.5 to 33.2. You were at 1.9.
Good Lord.
Yeah. So this is,
Very
what caught my eye is that this might not be a primary hypogonadism at all.
Oh boy, okay.
Yeah. Which is actually maybe a good thing. You know?
Yeah.
Maybe. One thing I will caution you about, Noah, is going down on your TRT dose if you are making some silly decisions with contraception, as in not using it, as a lot of TRT guys think.
I don't know what you're suggesting.
Okay.
My wife and I hug and cuddle.
Sure you do. Right. If you're not using contraception, I would encourage you to start immediately.
I cannot deny or confirm these allegations, Madam Secretary.
I will
but
say,
I will take your advice under consideration.
It's not folklore.
It's not folklore. Well, yeah, see, I made a video about this. A guy that I know on TRT, I think you know him too, actually. Yes, you do. Anyway, he got his wife pregnant after being on TRT for like 8 months, and he was of the mindset that I have mostly been under, is that if you're on TRT and your testes are suppressed, presumably you would be sterile down there, or at least your fertility would greatly be reduced. And so, anyway, his wife got pregnant. They were surprised. I suppose now I have a fair warning.
Yep.
And thank you for taking away all the fun.
So it actually does happen. It's not just theoretical. I've seen it. So. And if you want to have a separate visit with your partner to talk about contraceptive options,
sweetheart,
I love having that talk with you.
No way.
So,
right.
Yeah. Every option stinks, so it's finding the option that stinks the least.
Saran wrap.
Don't do saran wrap. Don't do saran wrap. You won't enjoy it, and it won't prevent anything anyways.
Oh, God. All right.
All right.
So, final thoughts, so that we're going to put me on some vitamin D. We're going to slightly bump up the levothyroxine, which is T4 support, which has to do with my thyroid.
Mm-hmm.
And we're going to lower my testosterone from 0.8 to 0.5.
0.5.
But you don't want twice a week. You want a 0.5 one time a week. You're not at all worried about the half-life, and do you think at that dose it's like it's not going to be that big of a deal to have?
You know, considering that when you look at the package inserts on how to prescribe this medication, it's once every 2 weeks.
Oh, interesting.
So,
because I was always told the more frequent you dose,
right.
the better, because there's just less of this period. I mean, it just keeps you.
And we can do it that way, but part of why I wanted to set it up as this once a week thing was so that we could keep that therapy in place and then add the HCG as that second thing you do.
Okay, so.
But if it would make you feel a lot better, that twice a week is fine.
No,
I feel strongly about that.
I'll start with the once a week, and I'll do it for a few weeks if I happen to notice something drastic. Based on how high my numbers are, I'm actually crossing my fingers as a final thought that maybe this, like you said, you know, I have been dealing with exacerbated obsessive thinking. I've never totally gotten rid of the depression. In fact, it spikes up and down, so does anxiety. So I ride the waves of life, and I understand TRT is just one part of it, but I am hoping that if it can in any way, shape, or form, and I know you alluded to this, it could be a positive not to be over-medicated. And I buy into that. Like, I don't think more is better, especially when it comes to hormones. Like, I've hope to always be transparent on this channel and be like, I will do whatever I have to do to be well, and to live by that I have to listen to your advice, and I appreciate you. So we'll do that, and I hope it goes well, and we'll do it. We'll do it.
And
you see me like talking myself into it. We're gonna do it, man.
Right, it's gonna be.
Shit's gonna be perfect.
And if it isn't, it'll be a little embarrassing in front of the audience. Whoops. But I'm here for you. I'm here to bail you out.
Yeah,
and if it doesn't work, it doesn't work. We increase your dose. That's fine.
Guys, let's show Dr. Zelfand just an abundance of respect and kindness in the comments below.
You always have. Thank you.
She doesn't have to do this, and I'm not trying to patronize you. You guys probably know that. This is a really unique scenario to have someone like her willing to come on here, share her expertise. So please consult your physician in general. Use this as an educational thing, but it's certainly not meant to advise anybody on anything. We're just going over my specific stuff for my particular case. So use it as such. Thank you for your time. Thank you sincerely. Thank you for being willing to do this.
Pleasure.
We will hopefully have her on here again. I know we will, because
because I can't say no to this.
I know, right? There you go. But yeah, there's a lot to take in right now. I'm slightly spinning, but I think it's all positive. I look forward to it, and I appreciate you guys. And leave your questions, comments below. We'll see y'all in the next video. Peace. What was that? I don't think I've ever done an outro like that. What's up, y'all? We'll be cracking off the next one at the next time. Peace out.
Okay.
That's quite.
And that is all she wrote.
And that is definitely all she wrote.